So you've probably got a button that comes up and says, are you okay with the recording? Make your choice, yes or no, and we go from there. Thank you. So as you know, this is Macular Degeneration New Zealand. We're very grateful to have you here. This is one of the things that we've now started doing, which is these seminars by Zoom, as well as face-to-face. If you're in Thames Coromandel and you'd like to see a face-to-face session, we're doing this on this coming Saturday. Please get in touch with me or send me a message and I'll put up the information after we have finished this presentation and answered all the questions. We're also undertaking one in Invercargill on the 20th of August. So if you'd like to attend either of those, please do that. You can just type a question into the chat, Trish. Don't worry about the raised hand. That's perfectly fine. Right. So as you know, I will be sending you an evaluation form that's online after the session. So later tonight for you to either complete tonight or tomorrow. It will be a little bit later tonight. So please do complete that because it helps us get funding and support MDNZ in the work that we do. So really important that you give us some feedback on how you found the session and if there's anything that we can improve. This is our third session by Zoom. So we're still learning on how to do this and how it works for you. But I'm now going to hand over to Tracey and let her start her presentation. So I'm going to share the screen and hand
over. Thank you, Anna. And thank you everybody for joining in and zooming in. You're all interested in macular degeneration, which is a really important topic. So I'm really glad you're with us this evening. So we're just going to get going. We're going to cover tonight all about macular degeneration and what it is, what you should look out for, what you can do, and what sort of treatments are available and coming. So let's get started.
I used to go down to the beach and I used to be able to read without glasses at all. I'm short-sighted, but used to be able to read in the sun without glasses. And I noticed that the print was just not as clear as it had been. So I then put on my, my ordinary glasses for short sight. And within a couple of weeks, I noticed that again, the print was blurry. A couple of months later, I was having lunch with some friends and they said that a friend of theirs, he was going to an ophthalmologist who was absolutely brilliant, and why didn't I go along to see her? So I started with my first injection in December 2007 and had one then in January, and to be honest, I actually didn't notice any difference in my sight. And then I had the third injection and I was sitting with my boss and I caught him staring at me and I said, "Why are you looking at me?" And he said, "Viv, you're actually doing your shorthand without either your magnifying glass or your magic glasses." And it was the first time I began to get a little bit excited. And I had the fourth injection in March, and I knew that I could actually see so much more. But at April, she did the scan again, and I had reached the level on the eye chart where I could once again drive and read the newspaper. Because for everyone, there is hope in some form or another.
So we're going to get started talking about macular degeneration, and we're going to find out a little bit more about it this evening. So with some background facts, what is macular degeneration? Well, this is vision loss, which is affecting the central vision, and it's progressive. It's important to know that it doesn't affect the peripheral vision. So even at its worst, you won't lose your vision completely. Compared to other conditions, macular degeneration is 3 times more common than dementia and half as common as diabetes. And in terms of other causes of vision loss, it is really important. It's quite huge. It makes up almost half of the causes of vision loss that are registered. And that's way above cataract and glaucoma. So the biggest risk factor for macular degeneration is age. And once you get to 50, 1 in 7 people will have some form of macular degeneration. As you get older, so into your 80s, it affects 1 in 4. And it's associated with other conditions as well. So you're more likely to have falls, have depression, suffer a hip fracture, and compared to those without macular degeneration, you may enter a rest home 3 years earlier. The second biggest risk factor for macular degeneration, you can't do much about your age, but you can do something about this one, is smoking. And smokers have a 4 times higher risk of macular degeneration than non-smokers. And if you smoke, then you're more likely to develop changes 10 years earlier. The other major risk factor is family history. So if, for example, your parents have or had macular degeneration, then you've got a 50% higher chance of having that tendency towards macular degeneration than otherwise. So it's important, if you know that there is a family history, to get checked, or if you have macular degeneration, to tell your family so that they can get checked as well. So macular degeneration, what is it? It is age-related macular degeneration. So sometimes you'll hear people talking about MD, but sometimes you'll also hear them talking about AMD or ARMD, and it's just to make it clear that it's age-related macular degeneration. It isn't macular changes which are related to trauma, for example, or changes that occur at the macula from autoimmune conditions, or that you're inherited, which is, for example, macular dystrophies like Stargardt's. It's not those things, it's related to just aging change. So to understand a bit more about this condition, we need to know what part of the eye we're dealing with. And so we're just going to go over a little bit of anatomy. We've got this picture of an eyeball here, which has been cut through in a section, and we've got the top of the eye, the front of the eye at the top of the picture, and the back of the eye at the bottom. And so you can see that orange layer is lining the eyeball, and that's the light sensitive tissue, which is called the retina. So the macula, I explain to my patients, it's the middle part. The middle part is the macula, or the central part, and it's responsible for the most detailed vision. It's what you use to read with and drive with. And you can also see in that diagram, there's a little round spot at the back, that white spot, that's the optic nerve. It's like the cable that sends the information from the retina off to the brain to process those images. So another way of thinking about the eye is like a camera. So if you think about the front of the eye taking in the light, and it's getting focused by the cornea, which is like the clear window of the eye where you put a contact lens, and then the lens itself, which can sometimes form a cataract later in life. It focuses images onto the back of the eye, which is the retina, which acts like the film in a camera. And then the optic nerve will send those off to the brain to process them, and that's how we see. So on this slide, what we have is on the right, we've got an example of an OCT scan, and that's a machine that we use very widely when we examine patients and investigate them and follow them up. So this gives us a section through the back of the eye, looking at the retina. So, Anna, can they see my mouse there? Okay, great. So what we're looking at on this black and white picture to the right is a section through the retina in the very middle. And on the left, we've got blown up what's in that red box there. And that's where macular degeneration affects the eye. So on this side, we've got the retina, and it's sitting on some other layers, which are the pigment epithelium, a membrane there, and it sits on top of this vascular plexus or spongy layer of blood vessels called the choroid. We're going to have a better look at that in the next slide. So there we go. Again, the retina up the top, and we're looking at the deeper layers of the retina. And then underneath that, we've got a pigment layer, which is called the RPE, or retinal pigment epithelium. And it sits on a membrane, and that separates it from this vascular layer underneath, which is called the choroid. So in macular degeneration, what happens is that we get changes in these outer layers, and the retinal pigment epithelial layer, which does a few things, including nourishing the retina and taking away waste products, doesn't do it quite as efficiently. So we get some buildup of some of these waste products, and those deposits are called drusen. We also get some thickening of that Brooks membrane, which is underneath that. And as changes progress, we can get wet macular degeneration. And that's where some of the blood vessels from the bottom in that vascular layer, the choroid, grow through some cracks and they leak and potentially bleed in the wrong spot being underneath the retina. So another way of being able to image those changes, we can use the same machine, the OCT scan, and it can produce these nice images. And it's showing in this layer, this abnormal network. It looks a bit like a flower or a fan shape, but this is an abnormal complex of vessels from the choroid. And these are the abnormal vessels that we were looking at the slides just before. So there are two main forms of macular degeneration. There's dry and there's wet. And dry makes up the majority of macular degeneration. It's about 90%. And only about 10% of dry macular degeneration leads to very severe vision loss. And the flip side applies to wet macular degeneration. There's a minority of people that have wet macular degeneration, about 10%. But the majority of those people will have quite marked vision changes. And on the whole, dry macular degeneration tends to be quite slow and gradual, whereas the wet macular degeneration can be quite rapid and it can be quite sudden and severe. So if we were to take a photo of the back of the eye, and this happens to be a photo of the back of somebody's left eye, what we've got in this photo is an example of dry macular degeneration. This round structure here is that optic nerve that we were talking about, which is that cable. So we're seeing the very end of that plugged into the back of the eye. And what we're looking at here, these branches, those are some of the retinal blood vessels, just like we've got blood vessels in all parts of our body. So this part to the right, in the very center of the photo, is the macula. And we're seeing some dark spots here, which are some pigment changes. We're also seeing some very well-defined white spots, which are areas of atrophy where it's worn out. And off to the right, we can also see some other white spots, which are some of those deposits of those waste products which build up. And we now know from the talk a bit earlier that those deposits are called drusen. In wet macular degeneration, we can get all those changes, but then we also get additional changes, such as thickening and swelling, and evidence of those blood vessels bleeding. And that's what these bruises are showing. This happens to be another photo of somebody else's left eye with the wet macular degeneration changes on top. So one way of classifying macular degeneration besides wet and dry is the severity. So we can separate it into early, intermediate, and late, and that's important for how we're going to deal with it. Within that late category, we've also got late dry changes, and we've also got late wet changes. In amongst this early and intermediate stages, those are all dry. So if we look at early macular degeneration, it's a little bit difficult to see on this photo, but there's not too much going on. We've just got very small, fine drusen. And as we progress, if you do go on to progress and develop a more severe form, intermediate macular degeneration. Those drusen are more obvious. In this particular person, there's more of them and they're bigger. And the main thing is that they're bigger in size, those drusen. And we're also seeing some soft drusen. And ophthalmologists also look at drusen and call them hard or soft, and it just depends on their appearance. So these look like soft drusen. They have very soft outlines to them. And having soft drusen and large drusen is a risk factor for progression. So we call this type of looking eye an intermediate age-related macular degeneration. We've got two photos of examples of late macular degeneration. So on the left, we've got late dry or late atrophic macular degeneration. So in this photo, we've got a well-defined worn out patch there. And sometimes we refer to these as geographic atrophy because it reminds us of maps. So if we think about the retina a bit like a carpet, then we're seeing a very threadbare area there where it's all worn out and we're just looking at the layers just directly underneath it. On the right-hand side, we've got an example of another wet macular degeneration where it looks thickened. And we've also got some bruises which show that there's some abnormal blood vessels which are bleeding. So what might you expect if you have macular degeneration? Some of the symptoms. Remember we said that macular degeneration is vision loss in the center of your vision. So if you look at this photo, with macular degeneration, you might notice this guy in the middle and the guys around him have become a bit distorted. As things might progress, then they might get more blurry and they might even be difficult to see altogether. There might be a patch in your vision right in the center. Other things people describe are just blurred vision or loss of contrast. And a lot of my patients talk about the issues they have with reading. When they read things, the print looks distorted and parts of the words might be missing, so letters might be missing. So we usually ask people who have macular degeneration or have come in for macular checkups to monitor their central vision, and we ask them to do this with an Amsler grid, which is a normal example is on the left. So the Amsler grid is printed with a dot in the center, and it has lines that are printed straight up and down and across. And the way we get you to test your vision with this is one eye at a time. Hold it at reading distance, which for most people is about 1/3 of a meter. It doesn't matter if you tend to read a bit closer up than that or a bit further away from that, just as long as you do it the same way each time to keep it regular. And you keep your reading correction on. So if you use glasses or contact lenses to read with, you keep that on to do this reading vision test. And you cover up one eye. If it's over the glasses, you put it right up over the glasses and look in the center spot. And what you should be seeing is that the lines look straight up and down and across, just the way it's printed. If you have macular degeneration though, you might notice that some of those lines are not straight, or they're not clear. They might be distorted, wonky, or blurry, or there might be a patch. And if that's the case, you should get an eye checkup, either with an optometrist or with an ophthalmologist. So we're going to just do a special mention about this condition, and this is Charles-Bonnet syndrome, and it's remarkably common, although a lot of people don't report it. It's where with significant visual loss, people start to have visual hallucinations, and it can affect about 30% of people with quite marked problems with their vision. And oftentimes it's not something it's not particularly vague. It can be very vivid, and they can give very good descriptions of what they see. They're aware that these images aren't real and they don't have control over them. And it's often temporary. It can come and go. And if the vision can improve, then sometimes this problem of the visual hallucinations can actually go away. So you can be quite normal, but if you have poor vision, then you can get these visual hallucinations. And it's the brain's way of trying to make sense of the poor vision it has by trying to insert some information in there, which sounds like a good idea, but it isn't always helpful, and sometimes it can be quite disturbing. So what can we do about macular degeneration? That's where we go back to those categories we talked about: early, intermediate, late wet, and late dry, and we're going to run through that now. So for early, it's about identifying if you're at risk, especially if you've got a family history, and getting checked up. And it's about keeping yourself healthy. So the number one thing is not to smoke, and having a healthy diet, which we'll also talk a bit more about soon. For intermediate macular degeneration, large studies have found that you might benefit from supplements that help macular health. And our information from that is derived from these major studies which came out of the United States. There was a part 1 and a part 2, AREDS 1 and AREDS 2. And the reason why it's called AREDS is across the top. It stands for Age-Related Eye Disease Studies. And these looked long-term data over hundreds, if not thousands, of patients. And one of the things they looked at was, do vitamin supplements, added nutrients, reduce your risk of progression of macular degeneration and getting very poor vision. And they found with their particular formula, which we'll show you soon, that it did reduce the risk of advancing to late macular degeneration by 25%, and it reduced the risk of severe vision loss by almost 20%. So some examples of supplements that are available to buy here in chemists are Blackmores and clinicians, and these follow the AREDS formula. And I would recommend that if you are going to think about getting supplements, that you at least get something that's following the formula that was shown to be of benefit, rather than grabbing different things. Number one, though, is to stop smoking if you smoke, and that applies to all stages of macular degeneration. So some of the things that might help in the diet are nutrients like lutein and zeaxanthin. And there's some talk about the Mediterranean diet, which is supposed to be quite good for lots of conditions, including macular degeneration. It's those plant-based foods, so lots of fruit and vegetables. And in terms of vegetables, we're thinking about the green leafy vegetables that have lots of lutein and zeaxanthin. And also keeping yourself active, stopping smoking again, considering supplements and having a lutein supplement, especially if you're at risk or you have a family history and are over 50. So on the right-hand side, that's the formulation that those ARED studies talked about as having some benefit in reducing your risk of advanced macular degeneration and severe vision loss. So it includes zinc, copper, vitamin E, vitamin C, lutein, and zeaxanthin. I would say that if you are going to consider taking supplements, that it's always a good idea just to let your family doctor know, just to make sure it doesn't interact with some of your other medicines, or that it's not going to cause any trouble with any of your other medical conditions. So now we get on to late wet macular degeneration. Without treatment, and this was the situation we were in about 15 to 17 years ago, we had no treatment for macular degeneration. Without treatment, 75% will go blind after 3 years, and most of that loss of vision will happen early on, so 50% will lose vision by 3 months. The longer you delay treatment, the more vision loss you might expect. So that's why it's really important to get checked if you've got any concerns, especially if you've got symptoms or have changes on your Amsler grid. Because if you delay it by 3 months, you run the risk of losing 1 line of vision that you might have kept or gained. If you leave it for 1 year, you might lose 3 lines of vision. And at 2 years, 4 lines, and that's lines on the vision chart, which we've got on the left, which you might be familiar with if you go to your optometrist or your ophthalmologist. you'll usually start your assessment by having your vision checked on each side. So this diagram is just looking at all the different elements of how we can maximize your vision. So one we've just talked about is getting seen and diagnosed quickly and getting treatment started as soon as possible. So the treatment for wet macular degeneration is injections. And what we're injecting is a drug that works against a factor, which is called VEGF. It's a growth factor, it's the GF. And the VE stands for vascular endothelial. Sometimes we call it VEGF or VEGF if we're being lazy. So VEGF causes blood vessels to grow, and some of the drugs we have available block the action of this, so it can stabilize the vision and prevent further vision loss. So the drugs we have available at the moment, we include Avastin, Lucentis, and Eylea. So Eylea is one example of this. Eylea is the brand name, but its true name is aflibercept. And compared to the others, it does seem to bind a bit stronger and for longer. So after the initial treatment is started, and often with all of these drugs and all of these injections, we're starting off with monthly injections. Once you become more stable, you can often try and start extending the treatment interval out between the injections. And in Eylea, sometimes we're able to do that more easily with the Eylea than with some of the other drugs, so that we're able to get out to 8 weeks between injections or even up to 16 weeks between injections. So Eylea became approved by Pharmac a few years ago, but still in a limited availability. It's not available for all uses that we would use anti-VEGF treatment for. It's just limited to macular degeneration and diabetic macular edema. So some of the other conditions we might use it or might want to use it in, such as vein occlusions, we're not able to use it for that. So what the injections do, we've got two pictures of some OCT scans, and remember I said that we use OCT scans very often in our assessment of patients and following them up. In the top OCT scan, you can see that the retina, so the retina is from the top here down to the bottom, and it's related to a lot of swelling. It's thickened and swollen, and it's also on this picture got some fluid underneath the retina. We call that subretinal fluid, and that's that dark space there. And after 3 treatments, which would have been a month apart with Avastin, this patient's scan looks more normal. So the structure or the anatomy has become more normal, and their vision has come back to normal, which is great. Another way of looking at it, we don't use it quite so often. We usually use our symptoms and our vision chart test and our OCT scans. But another way we could look at the effect on the new blood vessels is with the OCT angiogram, again using that OCT machine to give us slightly different information. But we see that network of new blood vessels shrink up after having some treatment. So this slide is quite busy, but what we're looking at here is over time. So we're going from 0 to 12 months. Without treatment, you're in the negative, so you're losing vision. But with treatment, now that we have that available, you're more likely to gain vision, and it will stabilize over time. Most of that gain happens in the early stages, so within the first 3 or 4 months. So from lots of studies and trials looking at the effects of these medicines, we know that in these studies, the patients that were treated very regularly, 95% were able to achieve stable vision, and 30% were able to improve vision. 40% were able to retain their driving vision. This relates to the patients that were in trials, so being treated very regularly, a little bit of an artificial environment. We think that in terms of real world data, it's more like 50 or 60% of patients can achieve stable vision. And that's because out in the real world, the situation's a little bit different. You're not in a controlled study environment, so there are going to be other sort of factors that are going to get in your way, and you're not necessarily going to come back every month, even if that's the initial plan. So the next factor or element of maximizing your vision is recognizing that it is an ongoing treatment and it is for the long term, because this is a chronic condition and it involves having chronic treatment. So that takes a little while to get your head around. That said, sticking with it is going to give you your best chance of maintaining your vision, but we know that there'll be obstacles in the way. There'll be things like COVID, there'll be lockdowns, there'll be isolating, there'll be other things that will get in your way. But as long as you just stick with it, do your best, then you're in for a good shot. So currently our treatments are these regular injections, which most frequently would be usually about every 4 weeks or every month, but extending as you improve or as you respond. We hope that within the next 5 years, there'll be newer drugs available, and hopefully that these will last longer, because like any kind of medicine that you take, whether it's an injection or a tablet, it will have a limited time that it spends in your body before it gets cleared away and then loses its effect. So we hope with some of these newer agents, they'll have a more long-lasting effect, and you will hopefully be able to have the injections more further apart. The other thing that people are looking at is different ways of delivering the drug. So instead of injections, there's a thing called a port delivery system, and we'll see that on the next slide. And then also looking at ways of personalizing treatment, so we get an optimal sort of regime for each individual person, because not everybody's going to be the same. In 10 years' time, we might have gene therapy available, and that would be amazing, because with a single treatment, we might be able to get the eye to do all the work and make its own sort of anti-VEGF agent and sort itself out. But it's a bit further into the future. So we mentioned the port delivery system just before. So instead of having these frequent injections, there's work being done looking at a different way of delivering the drug, but it involves having this system inserted into the eye in the operating theatre. And so this, what you're seeing here, which is what you can see on the surface of the eye, which would be underneath the eyelid, is that part there. And this device slowly releases medicine into the eye, and then it just needs to be refilled when it runs out, which is usually in about 6 months' time. So they've done work with this particular delivery system and Lucentis in the big studies such as the Archway study. So with late dry macular degeneration, we don't have injections, at least not at the moment, for this condition. But it's important to remember that there are things that you can do to help you cope with your vision and get the best out of your vision. And that might involve getting a low vision assessment, where you can get some advice on what's the best lighting. And optimal lighting is really, really important. Help with what's the best magnification, which might be a hand magnifier or a stand magnifier, and making the best use of contrast.
So much that is precious we see with our eyes, but your sight may be at risk. Macular degeneration, or MD, is a disease that affects 1 in 7 New Zealanders over 50. Left untreated, MD can lead to total central vision loss. But some forms of macular degeneration can be treated if diagnosed early. Detection starts with this simple test. Will you take the test or turn a blind eye?
So thank you so much, Tracey. That was really, really good. Thank you so much. I always learn something new when I listen to every ophthalmologist. I've been doing this role now for 2 years, and heard a few ophthalmologists talk about it, but I always love how they explain it differently, and I always pick up some new bits and pieces. So thank you, Tracey. There are a few questions. Now, a lot of them are actually to do with the supplements. So I just wish to point out that when I send the survey out to you, if you haven't already got it, you can actually get our patient pack as well. And in our patient pack, we have a nutrient and supplement form. And that has the ARID study details and explains what Tracey was talking about. And it has the details of what you should be taking in the ARID study and the quantities that you should be looking for. I will ask a couple of these to Jeff, please just contact me because I can take you through the Blackmore supplements. So give me a call tomorrow because that sounds like more of a personal conversation, and happy to do that. Somebody was talking about Sanderson One Day Vision FX, and I just looked that up while Tracey was doing, just to see what it was and where it sits. It definitely has all the items, Tracey, but it's not exact. Like, it's got less of some and more of others, which is quite interesting. We do try to encourage you to stay to the ARIDS formula, which is in that nutrient supplement, as close as you can, because whenever they do these trials, Tracey, I'm right in thinking they're quite specific, aren't they?
Yeah,
about what their successes are and so forth. So if you love Sanderson and it's working for you, of course, please stay with it. But if you're looking for a supplement, we would encourage you to try and stick to what's in the ARID study. So that's with 2 milligrams of copper, which Sanderson hasn't got. It's only got 1. Vitamin E at 400 IU, vitamin C at 500 mg. You might also take other vitamin C or eat more food that has vitamin C in it, but Sanderson's only got 150. So there's a few things like that that are just a bit different. If it's working for you and you like it, as I said, please keep going. Again, with the Preserve Vision, I've heard of other people using it. Can you get it, Beryl, if you can unmute yourself, if you're able to? Is Beryl still here?
Yes, I can hear you now.
Hello, Beryl.
Hi.
Have you tried ordering it online? Just
No, I haven't, because when I first developed macular degeneration years ago, this was one that that Archie McIndoe recommended. Archie McGeorge recommended for me, and I've just kept it going. But it's horrendously expensive, and because it doesn't come up on the GP's computer, every time I want it, I have a problem. And
you can't. None of these are funded, so
no,
none of these supplements are funded. So that's why we always say we love, like, the thought of you being able to take this. And there's a few questions in here as well, Tracey, about the success or the use of them. Am I right in thinking that the ARID study only indicated that it became successful at intermediate level?
that's right. So if you have early macular degeneration, it's not a big benefit.
Okay, so there's a couple of questions in here about people asking, should my 40-year-old daughter take it because it will it help prevent her getting it? That's not what the studies showed. It's if you have intermediate, so you've been diagnosed with it and then you have it. Beryl, do try getting it online. You might be able to actually just get it directly.
Okay.
Overseas, so give that a go. I have heard somebody was successful, but I don't know which website they used.
Okay.
So that might be worth your while if you want to stay with it. Preserve Vision was one of the originals, obviously.
Yes.
And I have heard about it. Is the medication just effective if the error is hereditary? By comparison, if the person smoked or instant? Vivian, I'm taking you mean the injections, the effectiveness of the injections. Is that what you'd want Tracey to answer to? I think that's what she's talking about, Tracey. Is there any impact upon the effect of the injections, of the Avastin or Eylea?
We don't know for sure, but generally your outcomes are generally worse on if you are a smoker. We know that they don't tend to do as well.
Okay, that's interesting.
First of all, you develop your macular degeneration earlier, and you are more likely to have macular degeneration, but also it's anecdotal, but the patients I have that smoke tend to not become stable as easily as the ones that don't smoke. But to be fair, I don't have many patients that smoke now, so it's a little bit difficult to judge. We don't have hard data on that.
Thank you. Jan and Leonie, I hope I've answered your questions. If not, please come back to me. Is there anything on the horizon for late dry? I know that Apellis has been doing some research in New Zealand that has potentially got some good signs. I don't know about yourself, Tracey, if you know of anything else.
There's still nothing readily available that I know of that's coming out very soon, unfortunately, but there's still lots of work going on in these areas.
Yeah. So I know Apellis is trying an injection similar to the treatment of wet that slows down the growth of drusen in the eye, and therefore, but it's my understanding is dry is quite hard because of the fact that it's so slow moving for them to be able to assess in a trial whether they're being successful.
There is some data that's due out later this year and next year on some dry macular degeneration treatment, so we're looking out for that.
Cool. If you have MD in one eye, are you likely to get it in the other?
Yes. The short answer is yes. Different eye, but same body, so yes. Yeah.
Not 100% though, is it? You might
No.
not, but you're likely to.
Yes. And if you are getting treated for one eye, generally they'll be checking the other eye at the same time, and you shouldn't forget to monitor your good eye as well, just so that people don't forget that we're not all focusing just on the one side all the time.
Is there a risk doing downward positions in yoga? I know these are contradicted in glaucoma.
I haven't heard of any problems in relation to macular degeneration. No.
Somebody's indicated in the chat that they were very happy with Blackmore's as well.
I'm sorry to interrupt. Dr. Wong, when you speak, it's very difficult to hear you.
Sorry.
It's okay.
I'll move her a little bit closer. Thank you. How's that? Is that better?
I can hear you all the time, but I couldn't hear you.
Sorry about that, Trish. I'll
Now
speak
that's
up.
better. Yes, we can hear you. I can hear you now. Thank you.
Sorry. Thank you, Trish. I've got such a loud voice. Is Macutech an Australian brand? Yes, it is. And it is one of your options. Absolutely. It hasn't been signed off by the New Zealand Health Board, Medical Board, though. All right. So ones that are sold in New Zealand are signed off by our processors to be sold in New Zealand. If you purchase something from another country directly, there is a chance they haven't been signed off. But Macutech is Australian and it is available, and I do know people who use it. Do the injections hurt so much in New Zealand, whereas in Australia I had no discomfort with the same treatment? I think that comes down to who's doing it.
There's lots of factors involved. Most people tolerate the injections quite well. Obviously, no one likes the thought of injections. It does come down a little bit to the person, both ends, the patient and the injector. And I'm not saying that there's any problems with the patient. It could be related to the eye. So the most common problems we have people reporting after injections that the eye feels very sore or gritty or just really painful, like there's something in the eye once they get home and the anesthetic's worn off. I'm not sure if you're talking about that side of things, and that's often related to the eye being quite dry, and the things that we do to make the injection more comfortable tend to dry the eye out even more, so that exacerbates that. So until the eye settles down, and sometimes that can require using some extra lubrication, then it can be quite sore until things have sort of healed up a bit, I guess you'd say.
Can you please define late dry versus early dry again, please?
So early dry macular degeneration is just those very early signs, a few small drusen, and when we're looking at the eye, we're sort of determining what the size of them are. If you've got some larger drusen, then you sort of fall into that category of intermediate. Late dry macular degeneration tends to be more of that atrophic wear and tear change. So that's, I don't know if you remember that slide where there was sort of like that really well-defined area of atrophy, like a map. So that would be an example of late dry macular degeneration. Because that bit's essentially all worn through, you can't see through that part very clearly.
Does it help, Jeff? If you can turn your sound on and talk to us, you're most welcome to.
Yes, that does, thanks. But therefore I assume you could actually have early dry for a long time, and it might just stay as early.
That's right.
Okay.
Yeah, only raises your risk level slightly. So it's like a heads up, keep an eye on yourself, but don't panic type scenario, Jeff.
Yeah. Okay. Thank you very much.
Does sunlight damage eyes, especially in children, e.g. at the beach? Should they wear sunglasses?
Well, the general recommendation is for everybody to wear some sort of protection against very strong sunlight at whatever age. We're sort of knowing more about some of those effects now. And that includes for macular, but also for other parts of the eye that having a lot of exposure to bright sunlight isn't quite so good as we used to think.
Apparently, it can make a difference for the OCT if you see somebody who's worn sunglasses a lot.
That's very hard to know.
Hard to know?
Yeah.
My friend has regular injections with one operator, does it painlessly, two others she feels it. It's interesting, Trish, isn't it? Sometimes it's that way inclined. What is your view for laser treatment for dry available in Hamilton and Christchurch? I'm not sure that it's available in Christchurch at the moment. I know David Worsley does it in Hamilton, but I think he's the only one in New Zealand at the moment.
That's my understanding as well, but I don't have any information about it. I'm sorry.
Yeah. So for those who don't know, Dr. David Worsley is actually one of our trustees, and he still does the laser treatment. The problem is how do you identify, this is what I've been told by another ophthalmologist who used to do it as well, and in conversation with David, is is confirming whether it's been successful or not, or whether or not the drusen's going away by itself and so forth. So he offers it on the principle of if you would like to have a go and to see if it benefits you, then he's happy to do that with you, and he'll guide you through that. But it is not funded. It is an option that some people will go for because there is no other option at the moment, and it may be beneficial. But he is the only ophthalmologist who at this moment is willing to try it for you. So that's it. It comes down to a personal choice, really. Okay. So I hope that happens. So somebody's actually had it, expensive, but was willing to try. Yeah, I agree, Leonie. Not sure if it helped. It's really hard to tell. Some people, I think, have better success than others. Late dry has progressed to total blindness in my left eye. 9 years since diagnosis. The other eye is still usable, although addicted. I have taken daily Blackmore's lutein since diagnosis. Yeah. So as I said, one of our lovely ophthalmologists actually said that if it's a choice factor with the nutrients, like it's not a silver bullet that kills the werewolf, you're increasing or decreasing your risks by about 20% with the nutrients and supplements. They can be very expensive. If you just want to try and eat healthy, look after your eyes and not smoke, that is absolutely appropriate. And maybe take your grandchildren out for ice cream and enjoy life and reduce your stress levels. So it comes down to a personal choice and where you feel is better to spend your money. So just be aware. Is there any other questions that I have? Does anybody want to say anything? You can unmute yourself or take a few verbally if anybody would like to. Have we answered all the questions?
Julie here. I've been taking the clinician's vision care with lutein I get from the chemist warehouse, which is quite reasonable, 2 a day. Nobody's mentioned that, but the daughter's read all the info whatever surgeon gave me and decided that was the best. But what's your opinion?
Oh,
All
we
I've
did
heard
have
about is
that
black-
actually come up on our slide, Julie. So it was one of the examples. It
It
was probably
was.
just off to the side. I didn't actually see it so well because I had little people over it, but it was next to those 2 Blackmore's examples. And I think it's a good one because whereas with the Blackmore's one, you have to take one from one bottle and one for the other to make up your, to get your formulations worth. You just have to take 2 of the one bottle of that you're using, the clinician's one.
Right, which
Just
seemed
to-
easier. And
Yeah.
it's quite reasonable at the chemist warehouse.
Just be aware, please, that you don't get the full zinc with the clinicians though, so that is a benefit of the Blackmore's. However, that's better for some people because the full zinc can upset people's stomach and dietary systems as well.
Right, and I
So
have
it's a bit of a
IBS, so
balancing.
yeah, I have IBS, so I do take zinc sometimes just to help
Yeah,
with it.
yeah.
Thank you.
Be aware, we're actually, just to be clear, we're sponsored by Blackmore's as well.
Oh,
So
okay.
just to be aware, it doesn't mean
know
that it's
that.
the end all be all, but we do like them.
Chemist warehouse has theirs as well.
Yeah, it does. So whichever you prefer is absolutely up to you. Research from overseas indicates some success with red light therapy. I have started this as I have nothing to lose. Have you heard of it?
I haven't, but I'd be interested to know, find out how you find it, Trish.
Do you want to tell us a little bit about that, Trish?
Red light therapy, photobiotronic therapy is being used a lot for lots of different conditions, and the Mayo Clinic's using it for wound healing, for example, and I figure that that takes it out of the quack category. If the Mayo Clinic's prepared to use it, I'm prepared to look at it too. On a red light therapy Facebook page, where practitioners and patients, their users, discuss successes that they've had with it. Basically what it does is increase oxygen supply at a cellular level to wherever you aim it at. You aim this, this red light at whichever part of your body is requiring assistance or healing. So it's used for lots of things, for wound healing and for aches and pains, and yeah, it's best you go and look at it than I try and explain it. But I did read some detailed research about it as applied to macular degeneration, and I figured, well, I'm blind in one eye, the other one's going, I've got nothing to lose. So I've started using it, but I haven't been doing it long enough to report on its efficacy. And I guess because I have late dry AMD, it's going to be difficult to assess its efficacy anyway. You know, I have no way of measuring whether it slows down the development. However, since my left eye has virtually now no vision at all, except for a tiny little bit of peripheral vision in the lower left quadrant. On the outside of the lower left quadrant, I have a tiny bit of vision there. So it'll be interesting because I will certainly be able to gauge if there's any improvement. So, but I guess it's not going to be overnight, of course.
Yeah.
Yeah.
Interesting, Trish. I'm fascinated because I wouldn't have expected it to be of any impact with macular degeneration, because it's not so much about oxygen levels going to the wound. I can see that working with wounds. So if you do have feedback, please do get in touch with us again, because we'd love to hear more on that.
Yes, because I put it to how can it affect drusen? That's my question.
Yeah, exactly.
But I mean, only the effects will tell.
Yeah.
And it'll be up to someone smarter than me to figure out the physiology of it.
Well, you sound like you're fairly smart, Trish. So I'd be interested to see what you come up with that.
Well,
The laser treatment in Hamilton isn't to halt progression from dry to wet. It's to break up the drusen and slow down the dry.
right.
Okay, so that was a question, I think, from Lindsay, maybe. The Macutech compares like the clinicians does. So the clinicians and Macutech are very similar in their composition. So again, doesn't have quite the level of zinc, because that was a hard one for everybody to get past our health department. There's a comment on saffron. Do you have any thoughts on saffron? So we've heard some people have some really good impact from saffron. There is not enough research and trials completed for our medical committee to suggest that you take saffron. If you think it works for you and you like it, please do it, all right? If that's what you want to do. But it's not something that we would happily advise people that they spend their hard-earned cash on at this stage, because there's just not enough research for a medical committee to sign off. Not saying it doesn't work, just saying we don't have enough evidence at this stage. Is there anything else? Oh, Wendy, you've got your hand up.
Yeah, I
Please
wasn't
go
sure
ahead.
I wasn't sure how to do this.
You did well.
I've been having injections for 5 years. I've just had both my eyes have now got new cataracts. Do the injections damage the cataracts?
No, if they're done correctly, it's pretty difficult to damage a cataract. You'd have to be aiming in quite a funny direction to hit the lens. So a cataract is when your lens becomes more cloudy, and that's when we call it a cataract. So normally having the injections doesn't really go near that, and it shouldn't have any impact. Actually, the ARED study did sort of follow-up analysis of their patients, because they had so many of them. And recently they published information to say that having macular degeneration, if you have macular degeneration, then cataract surgery doesn't make that get worse.
Okay, thank you. Can I have one more question? In the middle of the lockdown, or the start of the first lockdown, I went in for my injections, and it was done in a tiny little room because they divided off the hospital for COVID. Mm-hmm. And it was a disastrous injections. I walked out of the hospital. By the time I'd got to the door, I couldn't see. So I was virtually blind for 2 weeks. It damaged my eyes completely, and the pain was absolutely horrific. I got taken back into the hospital in the ambulance, but what happened was I got my cataracts from it instantly. Have you heard of that happening before?
I haven't, I'm afraid. I'm sorry, Wendy. I'm sorry you had that really bad experience like that. I haven't come across that before.
Okay.
I'm surprised that you had 2 eyes done at once. Everyone I know that gets them has their eyes done alternately at different stages, different times.
She's talking about the injections, Trish, not the cataracts operation.
Yeah, so am I.
Oh, okay.
I don't know anyone who has both eyes injected at one appointment. Everyone I know has one eye.
You do now. I've been having it for 5 years.
That's become a bit more commonplace now to have bilateral or both eyes done at the same time now.
Wow.
Yeah.
People, like, for example, in the hospital system where we have a lot of patients coming through, we initially used to do them on separate occasions, and then we've moved to doing them on the same day. So that's become more of the norm now, not just there, but in other places and clinics as well. Although some patients will opt to have it on separate days, knowing that they'll need to come back for more appointments, because that does create extra issues with coming back and forth and transport and so on. But some people prefer it that way because they find they just manage a lot better having one eye at a time. But those would be probably a few of them.
Right.
Can I just offer one more thing? I have my injections without the pain relief injection, and I find the recovery a lot quicker.
Personalised service normally helps, Wendy, when you work out what works for you.
Yeah.
Don't be hesitant to tell them what works for you as well.
Thank you.
Diane.
I was just going back to the discomfort after the injection and the grittiness. Is it okay to put eye drops in your eye sort of immediately afterwards or on the same day?
Yep, it's absolutely okay to do that. A lot of doctors, nurses, whoever is doing the injection will put in some lubrication just right at the end of the procedure. For example, poly tears or polygel, and then oftentimes people have a script or they have a spare stash of lubricating drops or gel at home that they can carry on with taking at home, and that's perfectly okay to do.
So you can do it
that
immediately afterwards. Like
you can, as long as you feel comfortable doing it and you're not going to knock your eye. That would be the main thing. Otherwise, you might need someone to help you. So as long as you can do that safely, then there's no reason not to do that. That might help.
Is there any evidence of macular transplants happening?
They have done something along those lines, but that's hasn't really caught on because, well, what they've done is they've tried to shift a part of the retina that works better into the macular region, but that's very major surgery that involves having to lift up the retina, so create a retinal detachment, then move things around, and then on a separate operation, because everything's skewed, having to move the position of the muscle. So that really hasn't caught on or found to be really helpful to people in the long run.
I do know that there's stem cell trials happening at the moment to mend the macula, basically. And they're quite hopeful because the macula is quite close to the surface as far as a body part goes. So it's quite easy to access for stem cell. So that'll be interesting to see how that goes. Beverly noted, I think the iodine needs to be washed out well. Is that?
It depends because it depends on how much iodine they put in. So if they put in a whole lot, then probably yes. But a lot of people don't put in too much iodine. They just put in just a little bit. They put a bit around the eye, so to coat the eyelids, the outer surface, and the eyelashes. And then they just put a drop of iodine just on the spot that they're going to inject. And they leave that for 30 seconds. And usually the rest of the drops, like the anesthetic drops and so forth, do the washing out. So I personally don't use a whole lot of iodine all throughout the eye, so I don't generally need to wash it out. But that might be helpful.
My eyes weep a lot. Is that a macular thing? And my floaties are annoying.
Yeah.
Weeping a lot is usually the front of the eye type of stuff. That's usually to do with the ocular surface. So your eye will get a bit teary as a result of being irritated or dry, or else the tears aren't draining properly. So you're either creating more tears for some reason as a reflex, or those tears can't go away for whatever reason, either blocked ducts or something like that. So that's not a macular thing. With the floaties, it really depends what the cause of those floaties are, and then your ophthalmologist would be better able to tell you about that, because it could be lots of different reasons. It could be your retina, it could be the vitreous gel, which is inside the eyeball. So it really depends what's the cause of that.
Cool. How about I take one last question?
Could I butt in to make a suggestion, because I don't want you to disappear, but before I make it, I think it would be really useful in view of the number of questions and the 90 odd people who come on tonight, to have a Facebook page as a forum where people could discuss and ask questions. And
we do, so you can join our Macular Degeneration Facebook page.
Okay.
And if people ask medical questions, I will refer them to the committee and then get an answer back.
Fantastic.
You can also email our info@mdnz.org.nz, and we're very happy to come back and answer questions, Trish.
Thank you. Thank you.
Yeah, absolutely.
That I haven't found it yet.
So when I email out, what I'll do is I'll email out the link to the Facebook page, and I'll email out the survey. It'll probably be tomorrow morning that I do that. So just when you all get an opportunity, just jump on and do the survey. That would be lovely.
And thank you very much to both of you and everybody else tonight. It's a very
Thank you, and thank you for joining us.
learning forum.
Any last question? Or are we good? Ian, you're waving. Do you want to unmute yourself, or are you just saying goodbye? If everybody's all done, I will finish. Thank you so much. Very appreciate you coming along and allowing us to record this, and also to for all your questions. Been really appreciated, and giving us your time. As I said, you're welcome to get in touch with us either at the 0800 number or by our website or info. If you'd like to come along to one of our face-to-face and meet another ophthalmologist and ask them more questions, you're most welcome to as well. Jump on our website, all the information is there. I'd like to say thank you to our sponsors, which include Bayer and Freemasons and numerous others that help us out as well. So thank you, everybody. Have a lovely, safe evening, wherever you are in beautiful New Zealand. Thank you. Bye-bye.
Really annoying.